Dr. Rajeshwari Chitti. She will present a case of ocular cysticercosis. In the meantime, Dr. Tisha Vasant should be ready for the next case.
Good afternoon, everyone. Myself Rajeshwari Chitti. I am going to talk about a case of ocular cysticercosis, an uncommon vision threat. So, coming to introduction, ocular cysticercosis is a preventable cause of blindness, and it is caused by larval form of Tinea solium, Cysticercosis cellulose, and ocular adnexa is noted to be the most common site of disease in India, and posterior segment being one of the most common site of the infection. 35% cysts were found in subretinal spaces, 22% in the vitreous, 5% in the anterior segment, and 1% in the orbit. So when extraocular movements are involved, superior rectus is most common site, and cyst reaches the subconjunctival space from the adjacent muscles. So coming to the case, here the 25-year-old male patient by laborer by occupation and resident of Uttar Pradesh came with the chief complaints of swelling, redness, pain in right eye superomedially since 1 month, and he complains of redness and pain in right eye since 15 days, and he also gives a history of fall of dust particles into right eye 1 month ago, following which swelling developed. And on examination, visual acuity in right eye was 6/12 partial, improving to 6/6 on pinhole. And on slit lamp examination, the swelling was located superomedially, measuring 1 into 1 centimeter approximately. It was soft in consistency, tenderness was present, skin over the swelling was normal, and lid edema and ptosis was also present in right eye, and associated with conjunctival congestion. And other rest of anterior segment was normal, and fundus examination was normal, and left eye visual acuity was 6/6, and rest anterior segment and fundus was normal. And patient was planned for excision biopsy of right eye, but on table the cyst was noted and sample was sent for HPE examination, which was suggestive of ocular cysticercosis, and he was also sent for MRI brain to rule out any neurocysticercosis, but MRI brain was found to be normal, and patient was put on medical management, that is he was started on tablet albendazole 15 mg per kg per day, along with steroids, oral steroids 1 mg per kg per day, and he was for 1 month and followed up after 1 month, and there was resolution of the symptoms and signs. Here in the picture you can see the cyst on table. This is HPE examination. The slide was showing inflammatory cell infiltrates and consisting of eosinophilic lymphoplasmocytes, neutrophils and histocytes. So unique was when the patient came with a history of trauma, so we thought it was a conjunctival abscess or also hematoma, but for a surprise on the table it was noted to be cyst, and which HPE examination also supported the same, proving it to be ocular cysticercosis. And the take home message is that the early detection and treatment are crucial for preventing permanent visual loss, and imaging like CT MRI is essential to diagnose and localize the cyst, as clinical signs can overlap with other conditions. Cysticercosis should be considered in patients with endemic areas with unexplained ocular symptoms, and prompt action at the earliest can prevent long-term complications, and also focuses on good hygiene prevention, focus on good hygiene, proper food handling and controlling human tapeworm infection. Thank you.
Very good presentation, Dr. Ishwari. One thing just I wanted to add, because something which we routinely do is ultrasound. Was ultrasound done for this patient?
No, sir.
Because in myosisticercosis and orbital cysticercosis is very common in other ways, and it's a routine thing which should be done for picking up cysticercosis, which is located in the SRLPS complex, which is very common area. Other than that, it can also be found anywhere in the orbit as well. So preferably ultrasound is one of the earliest things which should be done, other than the clinical examination, and maybe an MRI or CT should be done afterwards. Okay, ma'am, you want to add something?
Diagnosis you made before you took him up for surgery?
No, sir. Like he gave the history of trauma, so
No, what diagnosis you made?
Like we thought it as a conjunctival abscess, and we thought of
Conjunctival abscess, and it came out to be
cyst.
Where?
Subconjunctivally, superomedially, the cyst was noted.
So that is what exactly is any orbital thing you have to image, you have to work up your patient well, you need to have some diagnosis before you take the patient for surgery. Because These are all well picked up on a simple imaging like ultrasonography or a CT scan or MRI, and all these facilities are available. So without proper workup, you don't take up the patient for further treatment. I mean, you have to have some working diagnosis. Second thing, you have said inadvertently maybe that subretinal cyst moved from the muscle. In the subretinal space, cysticercus, how does it reaches the subretinal space?
Through ciliary arteries it reaches. Circulation.
The lesion was outside the globe, right?
In general, she was describing the intraocular cysticercosis also. There you said that subretinal cyst, how does it reaches the subretinal area?
It is through ciliary circulations.
What?
Short ciliary arteries.
Okay. So you mentioned that through the muscle. All right. Okay. Anyhow.
So just one last word.
That's fine.
So the take-home message again would be that any of these trauma. In fact, I also encountered a patient who this child came with a similar subconjunctival mass, and the parent was so sure that they were. They were playing with the balloons, and with that toothpick that injury has occurred. So I thought maybe it's a foreign body that has led to a granuloma formation. The problem was it was so superficial that it would not be picked up with a B scan. So you need a UBM. And now how to do a UBM in a child? So I told them to get a CT. CT was not done. Even CT may not pick up, it is very superficial. So sometimes you do get into that dilemma, and actually the patient landed up finally with a huge mass, and it was saying that I'm cysticercosis. They ultimately come like that. The important thing is that although most of these patients would be treated medically, but you must do a good indirect or ensure that there are no intraocular cysts before you start your albendazole, one thing. Other thing is the neurocysticercosis part has to be checked for before you start your course of albendazole, and be sure that you continue the albendazole should not be terminated prematurely. What I have seen is as soon as the patient starts recovering, they just stop the medication. So always keep a watch for the scolex to disappear, and then you have to terminate your treatment along with a cover of steroids. Anything else?
This cysticercosis is very common. It's not that it is uncommon. It's very, very common. 15 milligram per kg body weight is what you have said. Yes. Of a 80 kg person, what will you give?
450.
Albendazole, the dosage is, how much is the dose?
15 mg per kg
per
body
kg
weight.
per day
DD.
in 2 divided doses? 2 divided or 3 divided doses or a single dose?
2 divided.
2 divided.
Yes.
80 kg person, how much dose comes? 120 how much comes? 120. And what is the tablet available? You have any idea? Albendazole? नहीं तो MBBS की बात पूछ रहा हूँ. 400 milligram. So of a 80 kg person, you are giving 120 milligram per day.
Yes.
No, sorry, it is 15 milligram. 1200 milligram. 1200 milligram. So you will give 1.5. How much? 400 milligrams. One tablet 3 times a day. Have you ever explained to them?
Yes.
No, have you ever explained to them that when they go and buy the tablet from the market, the chemist will say that it is a single dose treatment? Because albendazole, for whatever purpose is given, it's single dose treatment.
Yeah.
And it is available in a single tablet packing, isn't it, sir? So you have to really, this is practical thing I am saying.
Yeah,
Many times patient goes to chemist says कि भी ये गलत treatment है, इतना तो dose होता नहीं है.
No, we have experience, sir.
This is at MBBS level normally. Anyhow, thank you very much.